Hello, my name's Reid and I'm a Consultant Forensic Psychiatrist. I practice in the northeast of England and I work in a secure unit. I also have a role in strategic approaches to restraint reduction, but today I'm talking about my role as a doctor and how Safewards plays out in my day-to-day work. Clearly it's a part of a wider set of practices which include my clinical formulation, diagnosis and treatment of patients. And in forensic psychiatry there's a need for what we call relational security. I think at first, as I learned about Safewards, I saw that there might be a tension between relational security and Safewards, that they might push in opposite directions. However, I think that in fact they work together. So the reason why, for example, some staff had reservations about Know Each Other, the poster, which is supposed to create a sense in patients that staff are human by sharing neutral information, was that in relational security terms, staff are encouraged not to speak about their private lives on the ward. That's a sensible rule in general, but I think it's acceptable to not apply it to Know Each Other. So in Know Each Other, it's possible for me to have on a poster that my favourite saying is "one day at a time," and that I like singing and running, without creating any security sensitive information for people, and without blurring any interpersonal boundaries. I think it has the desired effect then that patients know that those are things they could talk to me about. I think it can be important for people with relationally complex identities perhaps, or with any uncertainty at all about what's appropriate to share or not share, should bring that back into relational security. So I suppose in that sense I've just engaged with the process. A specific way in which I as a doctor am involved in Safewards is that I take care to break bad news effectively in a way which mitigates conflict, and so that's become part of our CCRs, our CPAs, our quarterly review meetings for longer term patients. And I've piggybacked that onto some other risk management policies that we have in the hospital. Another way is that I try to make it to mutual support meetings, and I try to keep the fidelity to the model reasonably high. So recently I went in some supervision about mutual support meetings, and I've started to try and thank people whenever I attend a meeting, which feels awkward for me culturally, but I understand from the supervision I had that some of that awkwardness, some of that giving of yourself is good modelling, and it's only saying thank you to people. So I thanked the staff after our wards moved, and I also thanked someone for their patience over an issue which they had, a patient over them being waiting for nicotine replacement and some other things. So generally they're small steps, and they're mainly about being present and relating to people appropriately. And our violence has come down. Who knew, eh?